Hi, I'm Psychotherapy Cynthia. In this video, I will be talking about cognitive behavior therapy, also known as CBT. CBT is one of the most researched and widely used approaches, and it offers a very practical toolkit you can start using as a clinician in training. If you're a trainee mental health clinician, therapist, counselor, or social worker, this training is for you. We're going to deepen our focus on CBT techniques and strategies, what they are, why they work, and, most importantly, what they actually sound like in the room. We'll zoom in especially on core tools like identifying automatic thoughts, thought records and cognitive restructuring, behavioral activation, exposure, and behavioral experiments. Let's start with identifying automatic thoughts. In CBT, automatic thoughts are those quick, habitual interpretations that pop up in response to situations and strongly influence emotion and behavior. Clients often aren't aware of them at first, so your job is to slow the moment down and bring those thoughts into awareness. You might say, let's replay that moment in slow motion. You're walking into the meeting. Your heart starts racing. What flashed through your mind right then? Or, if that feeling of shame had a sentence attached to it, what would it say? You're helping the client move from, I just felt awful, to, I thought, everyone is judging me. Over time, they begin to spontaneously notice and report their thoughts in session and between sessions. Once you and the client can name the automatic thought, you're ready for thought records. A thought record is a structured worksheet or process where you walk through a specific situation, the emotion, the automatic thought, and then systematically examine evidence for and against that thought, ending with a more balanced alternative. For example, a client misses one deadline and thinks, I'm completely incompetent. You write down the situation, missed one work deadline. Emotion, shame, 80 out of 100. Automatic thought, I'm completely incompetent. Then you gently elicit evidence for the thought. What are the facts that support the idea that you're completely incompetent? They might say, I missed this deadline, and my supervisor was disappointed. Next, you explore evidence against. Have there been times you've met deadlines or received positive feedback? They might recall, I finished 3 major projects on time last month, and my supervisor praised my work. Together, you craft a more balanced thought like, I missed this deadline, and that's a problem. But overall, I've done good work. This is something I can address. Then you re-rate the emotion, maybe shame drops from 80 to 45. That shift is the heart of cognitive restructuring. Cognitive restructuring uses this process repeatedly to help clients develop more realistic and helpful ways of thinking. You can enhance this by naming patterns such as all or nothing thinking, catastrophizing, and mind reading when it feels helpful and culturally appropriate. Instead of arguing with the client's thoughts, you use collaborative, Socratic questions. For example, what's the worst that could happen? The best? The most realistic? If you were on a jury, would there be enough evidence to convict yourself of being a complete failure? Or, is there a gray area between total failure and total success here? The aim is not to convince the client that everything is fine. It's to arrive at a view that fits the evidence and lowers emotional intensity enough for them to act differently. Now, let's deepen behavioral activation. Behavioral activation is especially powerful for depression, where withdrawal and inactivity feed into low mood and hopelessness. As clients disengage from rewarding or meaningful activities, they get less positive reinforcement from their environment, which can worsen depression. With behavioral activation, you collaboratively map out which activities have historically provided pleasure and mastery or accomplishment, even very small things. You might ask, think back to a time when you felt a little better than you do now. What did an average day look like? What were you doing more of? Together, you build a menu of small, specific activities like sit outside for 5 minutes with coffee, text one friend, or take a 10-minute walk after dinner. Then you schedule them into the client's week, often using a simple activity schedule. In the next session, you review: what did you try? How did you feel before, during, and after? Even if mood doesn't lift immediately, you're reinforcing the link between behavior and mood and helping the client act on values rather than on depression-driven urges. Let's go deeper into exposure, which is central when working with anxiety disorders, panic, phobias, and OCD. The core learning principle here is that avoidance prevents clients from discovering that feared outcomes are less likely or less catastrophic than they expect, and it prevents natural reduction of anxiety over time. You start with psychoeducation. You explain how anxiety spikes when a person encounters a trigger. But if they stay in the situation without escaping or using safety behaviors, anxiety usually peaks and then gradually declines on its own. Together, you create a fear hierarchy, maybe from 0 to 100, where the client ranks situations from least to most anxiety-provoking. For example, for social anxiety, a 30 might be make brief eye contact with a cashier, while an 80 might be give a 5-minute presentation to coworkers. You then design planned, repeated exposures, starting with lower-level items. You might say, for this week, would you be willing to try saying hi to one coworker you don't normally talk to 3 times, and then we'll review what happened. After each exposure, you debrief. What did you notice in your body? What thoughts showed up? Did the worst-case scenario happen? What does this tell us about your prediction? Over time, you aim to reduce safety behaviors, like carrying a water bottle just in case, or constantly checking exits, that interfere with learning. Throughout, you're monitoring consent, pacing, culture, and context, and using supervision to keep exposure ethical and safe. Behavioral experiments sit at the intersection of cognitive and behavioral techniques and are especially helpful for testing specific beliefs or predictions. Instead of only exploring a belief verbally, you and the client design an experiment to see how the belief holds up in real life. For example, a client believes, if I set a boundary, people will abandon me. The two of you might design an experiment where the client practices a small, clearly worded boundary with a relatively safe person, maybe asking a friend to reschedule when they're exhausted instead of pushing themselves. Before the experiment, you clarify the prediction. On a 0 to 100% scale, how likely is it that your friend will be angry or end the friendship? After the experiment, you review. What actually happened? How did they respond? How did you feel afterwards? What does this suggest about the original belief? Even if the outcome is uncomfortable, you still gather data. What did you learn about your ability to handle the response? You can also do in-session behavioral experiments. For example, a client believes, if I cry in front of you, you'll think I'm weak. You might gently propose, would you be willing to experiment with allowing emotion to come up here and then checking in with me about how I'm actually seeing you? In these cases, your transparency and authenticity matter. You're modeling corrective emotional experiences in real time. All of these techniques, automatic thought identification, thought records, cognitive restructuring, behavioral activation, exposure, and behavioral experiments, rest on the basic CBT model that thoughts, emotions, physical sensations, and behaviors are interconnected and influence one another. As a trainee, you don't need to use every tool in every session. It's often more effective to pick one cognitive technique and one behavioral technique that fit the client's goals and diagnosis. Practice them repeatedly and refine your delivery based on the client's feedback and your supervisor's guidance. If you're a trainee clinician watching this, consider choosing one client this week with whom you'll intentionally practice a thought record, and another with whom you'll try a small, values-based behavioral activation task. Before your next session, ask yourself, what prediction are we testing? How will we know if this technique is helping? Then, after the session, reflect briefly on what worked and what felt clunky. That's where your growth edge is. If you'd like, in a future video, we can walk through full-length example dialogues showing a thought record, an exposure plan, or a behavioral experiment from start to finish.